Everyone, I think we are among friends here.
Yeah.
We have the folks from CARPL, we have the folks from Lunit, and the folks from GE.
Yeah.
So thanks everyone for coming to this. So TTSH has been partnering with CARPL for AI validation for a while now, and they have been very good partners with us. And this is just to share some background on TTSH, which I think everyone is very familiar with. It's a large-size hospital in the central of Singapore, 2,000 beds. And I think this slide comes from CARPL, and it shows actually the process of a typical validation project at a mid-sized hospital. And actually, AI pilots can be quite costly depending on the resources that we require. And I think the biggest cost factor, at least from TTSH perspective, is data access, as well as setting up the data pipelines required for this validation. So we can just take a quick look at this slide. From step 1 to step 5, there are multiple steps involved, starting from the decision to pilot, post-decision to pilot, as well as setting up the AI infrastructure. So CARPL has been very kind to us in setting up a air gap terminal in Tock Seng that allow us to do this validation relatively easily and at a low cost. And what this does is that it allows us to validate multiple different AI algorithms using the same platform with relative ease. So for example, we have been looking at chest X-ray AI, we have been looking at Thyroid AI, and we're also looking at AI applied to other parts of the body. So this is CARPL's AI marketplace. So it's actually fairly extensive, and I think it covers a lot of the use cases that we are actually looking at. Specifically in Tock Seng, I'm a head and neck radiologist, so we have been looking at KIOSK and C-mode. And from the general radiology perspective, we have been looking at Lunit and VinDr. I think we have been starting to talk with them. And the next area of interest for us is fracture detection, where Gleamer, SMAT would come in, and these are areas that we are interested in doing validation in. So one of the recently concluded validation projects that we have done is the Koios decision support. So what we're going to present today is really a subgroup analysis. So the background is that thyroid nodules with indeterminate cytology are quite common, and there is a risk of malignancy of 10 to 30%. So these nodules can be difficult to characterize without diagnostic surgery. So the usual workflow is that we detect a indeterminate nodule on sonography. We FNA, we biopsy these things, and it comes back with a Bethesda tree results, which is indeterminate. The next step after that is that the surgeon will need to remove the nodule for analysis, and the patient undergoes a fairly large procedure to remove half the thyroid gland essentially. So here we are trying to evaluate whether Koios can help us in further determining whether these nodules require diagnostic surgery. So what Koios does is that we can import the PACS images into the software. ROI is drawn over the nodule of interest, and ACR Thyroid is automatically shown here. Koios also has an AI adapter, which is trained on its own radiomics algorithm that provides a modification of the thyroid score. So it can either reduce or increase the thyroid score depending on the pixel data. So our methodology is actually based on a surgical database. These are post-thyroidectomy cases, so these are grounded in histopathology. Of these, those that are listed as Bethesda tree on cytology, meaning on FNA, were identified, and total number is 253. And of these 243 actually have ultrasound images for analysis. So we perform anonymization and ACR thyroid grading by head and neck radiologists. And for those with discordance, we have a tiebreaker with a senior member of our team. And all these ultrasound images will run through Koios, where the ACR thyroid's information is extracted. And CARPL's testing model actually generates the summary statistics quite easily for us to actually have a look at the AI performance. I think this shows AUC for AI algorithm for another AI product. But what it actually is trying to show is that you can actually monitor the AUC at a very high level, and if there's significant deviation, then you can do a deep dive to audit to see whether there is some kind of bias or there's some kind of something within the system that needs troubleshooting. So it's a high level detection and monitoring of the AI's performance. So what we have over here is a case from our test set. There is a slightly hypoechoic nodule with partially circumscribed margins. There are no punctate echogenic foci within this. So when looking at this nodule, the human radiologist, according to ACR thyroids, would rate this as a thyroids 4 nodule. So this is an intermediate risk nodule, and based on this size, it looks like at least 2.5 to 3 centimeters. FNA would be recommended. However, on Koios, this was detected to be a thyroids 2 nodule. And the reason is because of the Koios AI adapter. If you look at this, based on the points, it actually adds up to a ACR thyroids 4 lesion. But because of the adapter, it reduces the total score and rates it as a not suspicious category. And when we compare this case to our histology, this is actually a benign nodule. So it is one of the cases that show that the patient actually need not have undergone the diagnostic surgery. From the perspective of validation, CARPL is actually very supportive, and whatever cases that we have done the inference on, it actually goes into a database which can be extracted on the back end for us to perform further and deeper analysis. And these are the preliminary results. The details of this will be presented at a conference next month. But when we look at the call for FNA, which means that whether the software recommends for fine needle aspiration biopsy between this is Koios with AI adapter, Koios without AI adapter, and radiologist, there is actually no significant difference in the area under the ROC curve. And when we look at the sensitivity and specificity values, the sensitivity actually has no significant difference, whereas the specificity for Koios with the AI adapter in this particular subset has shown to be much higher than compared to the consensus of 3 subspecialized radiologists. So what this means is that Koios is able to identify cases that does not require diagnostic surgery specifically. So we can extrapolate this to the fact that we can reduce unnecessary fine needle biopsies. But of course, all these needs to be further evaluated after we have completed the full analysis of the entire data set. You can note that I didn't put any numbers up here, and this is intentional because the full data set will be presented by our team at a subsequent conference. So we have many ongoing collaborations with CARPL, and the first is a validation of chest X-ray AI, the Lunit model for deployment in primary care. We have a validation of fracture detection AI, which is upcoming, and the project that I just spoke on is a validation of thyroid ultrasound AI. There are multiple models that are available on the CARPL platform, so we are excited to move on the project to the next stage, which is to evaluate a second vendor. And CARPL has also kindly assisted us in the validation of large language models in the interpretation of radiology reports. And this is particularly interesting because A lot of the AI work that we are doing requires ground truth, and we are seeking the ground truth in the existing radiologist reports. And this is where we think generative AI can play a big role in generating this ground truth for us to monitor model performance. And this is work that is ongoing. My colleague Shu Wen there has done a lot in this area, and we hope to be able to present some of this data at a conference in the near future. Okay, so thank you. Thanks everyone. So I think we are all amongst friends here. So if you have any questions, we can reach out to me. Yeah, but once we have the thyroid data available, we'll be very glad to share with CARPL and also with GE, our friends at GE. Okay, thank you.
Thank you. Thank you. Thank you, Dr. Alvin.